Good morning and welcome to the North Yorkshire and West Yorkshire Joint Health Overview and Scrutiny Committee for Vascular Services. This morning I'd like to ask the committee members to introduce themselves, please. If we start with Councillor Rhodes. Oh, we seem to have a technical problem there. Councillor Baines.
Yes, good morning. I'm Councillor Stephen Baines, representing Coldsdale Council.
Councillor Godwin.
Good morning. Yes, I'm Councillor Paul Godwin, representing Bradford.
Councillor Hargreaves.
Councillor Robert Hargreaves, representing Bradford.
Thank you. Councillor Hutchinson.
Councillor Hutchinson, representing Coldsdale.
Thank you. And is Councillor Rhodes there? No, I don't think so. Okay, thank you. Right, so the agenda this morning, minutes of previous meeting. Do we agree the minutes that have been previously circulated from the meeting in February of this year? If committee members could indicate that they're okay with that. Thank you. Thank you. Interests. Are any members needing to declare an interest, please? No. No, thank you. And all the debates are in public. Deputations and petitions. Have we received any deputations and petitions, Richard?
None received, Chair.
Thank you. And public questions. Have we received any public questions?
None received, Chair.
Thank you. So now we move to item 5 on the agenda, which is Specialised Commission Vascular Services, and we've got representatives from NHS England and clinicians here. I wonder if you could introduce yourselves as you speak, please. I believe you're going to outline for us the position as it is at the moment. We have in the papers your response to the consultation, and your letter is in the papers, and in your letter you indicated that due to coronavirus crisis, the changes were not going to be immediately taking place. So I wonder if you could tell us where you are at this moment in time as part of what you're saying. Thank you.
Thanks, Chair. Thanks, councillors. I'm Niraj Bhasin. I'm a consultant vascular surgeon at Coldsdale and Huddersfield Foundation Trust, but also the regional clinical director for the West Yorkshire Vascular Service. So thanks for giving us the opportunity to update you on the progress we've made. And I'm pleased to report that despite the difficulties and challenges that COVID has brought, colleagues across all trusts have worked really hard to ensure that we've been able to maintain some momentum with this project. I think it would be easiest to structure my update based on the JOSC letter from the 12th of March to ensure that I capture all the details that you require. So the first was around sustainability of services. There was a point raised around trainees, and I'd just like to clarify that the recruitment issues have mainly been around interventional radiology specifically and not vascular surgery, and again mainly in the west of West Yorkshire. I know that Councillor Godwin and Councillor Hutchinson spoke about the Health Education England and training posts and essentially growing our own in this region, and I'm pleased to report that we have employed 3 interventional radiology trainees with an agreement across trusts that we will find the funding to give them an extra specialist year of training across the region to hopefully encourage these individuals to stay within our geographical region and give them the experience necessary. And I hope you agree that that's a real positive step. The next point was bed availability and access to theatres in Bradford. Obviously, I'm here as a clinical director of regional services and cannot express the intricacies of Bradford's operational planning. But what I can give is an overview that Bradford have identified 2 wards across which they can deliver a 39-bedded vascular unit, which we know from 3 methods of modelling would be sufficient. These wards, in terms of estates, are close to the vascular theatres. What we've also done is created other initiatives to reduce the in-hospital requirement and deliver care closer to home, such as the Urgent Vascular Assessment Clinic and a virtual ward, and therefore these other initiatives will supplement the response so that the bed base is not overwhelmed. Bradford have agreed how they'll deliver theatre capacity operationally of any work that will transfer. In addition to the physical space, they have a workforce plan to ensure that it is safely staffed also. The final point in terms of sustainability was the performance measures. So the operational teams have created a dashboard which will include all measures and monitoring through all sites. That will include standard operational measures such as referral to treatment times, length of stay, new to follow-up ratios, session utilisation and patient experience monitoring. We'll have clinical outcome measures such as morbidity and mortality measures, return to theatre, readmission rates. And finally, we've created a local and regional operational and clinical governance structure outlining local and regional meetings where performance will be monitored. These will be supplemented by incident reporting systems and serious untoward incident investigations if one was to occur. The second point that I'm going to address is the impact on other services at CHFT, and again specifically this was around the non-vascular interventional radiology. On the back of JOSC, we've created a work stream around this, and we have an agreement that CHFT will continue to provide an acute non-vascular interventional radiology service in hours to minimise impact on patients. In terms of out of hours, already at the JOSC, we had discussed how the numbers of these cases were very small. At CHFT, a senior clinical and operations team have undertaken an audit to identify exactly how many cases over the last year there would have been that would have needed out of hours non-vascular interventional radiology. And this has come out at 8 cases for a whole year. We have an agreement at Chief Operating Officer level across Bradford and Coldsdale about how these patients will be cared for. And we have a process now of getting the different parent teams together to create safe and robust pathways, communication agreements to ensure only patients who truly need out of hours transfer or treatment receive it, and they do so in the safest way. So I'll move on to the repatriation and rehabilitation points. Again, we've created a very significant multidisciplinary team to work on this work stream and address this. We have a clear agreement that patients will not be considered for repatriation until they are surgically fit for discharge, and there are no foreseeable issues which may require them to need any imminent surgical treatment. If there is anything that indicates they may need ongoing surgical input, they will remain within the acute surgical unit. We agree completely with the JOSC principle of ongoing care should be delivered as close to home as possible. And with that in mind, again, there's a detailed audit on capacity and a working ability to have a regional therapy lead. The idea of creating this role of a regional therapy lead is that they'll have an experience and understanding of discharge planning. They will already have links established across the region to facilitate that and work across those social care boundaries so that progress can be made on planning and equipment, for example, with wheelchairs, when the patient is still in a hospital outside of their own catchment area. We're describing creating a weekly discharge planning multidisciplinary team meeting to ensure that these patients are proactively managed and can return close to home as possible. We've also made progress in gaining an agreement that it's only those who need to be in hospital will be repatriated. If they're surgically fit and medically fit, but only need ongoing therapy and rehabilitation, there's a aim of patients to go home with community therapy support or into a community facility with dedicated therapy inputs. And again, with respect to that, we have a therapy team planning that and gaining assurance around capacity. That leaves the last cohort of patients, and those are the patients who need ongoing medical care but not surgical care. We know the numbers involved, and those numbers required have been incorporated into the CHFT bed modelling capacity, and there was agreement that they will repatriate into the most appropriate medical specialty for their needs, for example, cardiology or care of the elderly or diabetes. The final planning assurance that the JOSC asked for specifically was around the Yorkshire Ambulance Service. I've personally discussed this with the Yorkshire Ambulance Service leadership team, who have a detailed understanding of the plans, and we actually had Yorkshire Ambulance Services representatives involved in the creation of 12 regional clinical pathways. They're aware of the elective and non-elective demand and changes and have not expressed any concerns. The Yorkshire Ambulance Service have actually been added to a readiness safety checklist pre-go live or transfer of services, and they will be able to confirm that they are happy before we transfer any services. Just in response, Councillor Smage, to your original remark around COVID, and in terms of the go live, there is a planned date that we're working towards in mid-November. As I remarked, that will be subject to a safety checklist and assurance from all three trusts in terms of Airedale, Bradford and Coldsdale and Huddersfield, and the Yorkshire Ambulance Service to approve that they feel it's safe to move. This will be cognizant of COVID pressures and obviously winter pressures, and clearly NHSE and I will issue any further comms around this to the Scrutiny Committee and stakeholders at that point. So that's my update, and I'll pass on to Matthew at this point.
Thank you. I'm Matthew Groom, Regional Director of Specialised Commissioning for NHS England for Northeastern Yorkshire. So thank you, Neeraj, you covered a comprehensive update there. Just one area just to pick up that was noted was around travel. And there were concerns raised in the consultation also by the committee around the travel arrangements. And we were planning to meet, as we agreed in the letter, with the chief execs of Bradford and Leeds to discuss this, but COVID has obviously come along and delayed that slightly. But we are planning to do that, as well as with the combined West Yorkshire Combined Authority to explore transport links. I think one thing worth noting, though, is that one of the if you can say positive things that have come out of COVID is the adoption of technology by hospitals, and there's been a big push now to use technology to save people having to travel if they don't need to travel for some appointments. And so that will be a big push by NHS England over the next few years to embed that as much as we can. Now, this won't be suitable for everybody, and some patients it won't be appropriate for, but particularly when people are needing a follow-up or not needing that hands-on point of their care, then that can actually save them a lot of inconvenience if the technology works, and save a lot of pressure on the car parks as well, which I know is a big issue really. And so that is a big positive, but obviously that does not solve all the problems of the travel, of course. But I thought it was worth noting that is a positive change generally in parking at hospitals that is moving forward now. But as I said, we are committed to doing the actions we agreed, and we're looking at again dates now over the next few months to get those agreed. Thank you.
Thank you. And can I just welcome Councillor Hayden and Councillor Latty to the meeting from Leeds. We've had our own technical gremlins this morning, so welcome that you've managed to overcome those gremlins. You're okay. Okay then. So can I open up the meeting to questions from the committee, please? Does anybody have any points they wish to raise? Councillor Hutchinson. You're on mute, I think, Councillor Hutchinson. No, you're still on mute, Councillor Hutchinson. That's it.
Okay, thank you, Chair. Just a lag on the mute. I really do welcome the measures that Mr. Bassing has announced that have been taken since we last met, particularly the funding and the provision of 3 training posts in interventional radiology in the region. That really does go a long way towards addressing some of our major concerns in going forward. I would like to know whether those training posts have actually been filled now, and what the longer term arrangements are going to be to try and make sure we really do our best to grow the capacity of the training program to meet the ongoing needs in shortage specialties, because that really is key.
Thanks, Councillor Hutchinson. Just to clarify, these are, so we're absolutely clear. These were 3 existing posts, but what we've done is we've extended, what we've got the funding for is an extended year, almost like a fellowship year, to describe it sort of generically. And the idea is that will provide extra exposure within the region, in different hospitals in the region, embed these trainees in the region, and therefore encourage them to stay here, because we have an understanding of what, as you've said, what the service requirement is, but also what their personal ambitions are. So hopefully we therefore can match that to allow them to stay within the region. And the other question, yes, all 3 posts have been successfully filled. In the longer term, as you can imagine, that this was a sort of immediate response to the concerns we had and that were rightly highlighted by yourselves, and then we will continue to work with deaneries and Health Education England in the longer term to determine how we can expand that. But in the short term, I think it's a really positive response to what was required and to try and address some of the pressures within the service.
Chair, can I also ask the regional therapy lead, which again seems an extremely sensible and pragmatic way of trying to bring together everything that's needed for successful discharges of patients with the support that they need. Is this one post or more than one? Because if there's one post, presumably they go on leave and then everything falls to pieces during that time. Can you just tell me what the staffing for that is likely to be?
So we're working up a business case for it at the moment, but what I would say is we're completely cognizant of the fact that actually there's a relatively large area to cover, and as you've said, if someone's on annual leave or unfortunately falls ill, then we can't have the service collapsing. Theoretically, what we're exploring at the moment is that whether we were able to have a regional therapy lead for the west of West Yorkshire, that being the Airedale, Bradford, Coldsdale axis, and potentially one for the Leeds, Mid-Yorks axis, and therefore those 2 people would then be able to provide that cross cover that you've described. But in principle, this is what we want to do, and we're just working it up at the moment.
Thank you.
Does any of the committee have any other questions? Councillor Rhodes.
Thank you, Chair. Just to follow up on 2 items, do forgive me, I had gremlins at this side as well because we had a power cut, so we were offline. But anyway, just 2 items, if I may, to the previous presenter. First of all, I think I heard when I got back online that the post that Colin had referred to has got 12 months funding, the training post. Does that mean that when that funding is finished, that the training element will be reduced? And secondly, in the report, and as mentioned as well, the issue of having had the meeting with the Yorkshire ambulance people, it was mentioned that there's been a plan put forward, and I believe mention was made that there's support for 12 pathways within the plan. And obviously, I think it would be useful, Chair, if this information on the pathways and how they're going to reflect across the patch in general and the demand on the ambulance service could be given to the committee to evaluate?
In terms of the funding, like I said, this is something that we've just agreed. It's not that funding would be removed. It's the fact that at this specific point in time, what we're able to do is give those trainees an extra year, so they would come to the end of their training in any case, if you see what I mean, and then be applying for consultant jobs. I suppose what we would need to do is then reassess whether we have that level of seniority of trainee coming through, and whether this pathway has been successful in retaining those individuals into the service. So this is an initiative we've just put in. I don't think I'm in a position at the moment to say whether this will be a long-standing arrangement, but certainly it'll be something that's reviewed based on how successful it's been and the experience of the trainees. In terms of the pathways, these are clinical pathways applicable across emergency departments, across primary care and within hospital, amongst other specialties, for what I would suggest are the 12 most common vascular pathologies to guide treatment, referral and management. Once these have been signed off so far through a clinical working group, and once they've been signed off at our regional clinical governance process, then I will be happy to forward those on to your team. However, what I would say is that these are, technical documents that guide treatment, but if you feel having a view of that will be helpful, then I can't see any reason why I couldn't pass those on. In terms of the YAS demand, that's not information I have, but that would need to be an ask of YAS. But obviously, like I've said, we have engaged with them and they did not feel there were any particular concerns, because I think the point being is at the moment these patients are being transferred between CHFT and Bradford in any case due to the alternating arrangement. It's all that's happening is that alternating arrangement is changing into a single site. So the capacity, if you like, is not changing. It's just the ultimate destination will be changing. There's not going to be a change in, I suppose what I'm trying to say succinctly, there won't be a change in the volume of patients.
Thank you, Chair.
Thank you. Any other questions from the committee? Councillor Hutchinson.
Thank you, Chair. Can I just clarify about the online consultations or the remote consultations? Because from Mr. Bassin, what proportion of consultations that are required for vascular surgery can be conducted remotely, and what proportion actually require physical examination of the patient?
Okay, I mean, it's really difficult, as you know from your history, Councillor Hutchinson, to give you an exact percentage of what needs to be seen, directly and can be done through a telephone follow-up or video consultation. I suppose just to reflect what we've done through COVID, which in fact has been, as Matthew stated, it's been a real almost test of what we were planning on doing, because we very quickly had to revert to this technology and different outpatient working. What I would say that we have done is that we, just to reflect our practice within CHFT, because I think that's the sort of most accurate and fair thing to do, is that we've reverted to 6 face-to-face appointments daily, which are consultant-led. And then through the afternoon, we've maintained a daily template of telephone or video follow-up with the remainder of the patients that would have usually been coming to clinic, so either 8 or 16 patients being assessed remotely. If there are any concerns through those telephone follow-ups or video consultations, then what we would do is we would ensure that those patients are brought in and seen in one of the face-to-face slots. So that's what we've been doing. So ordinarily, what I'm reflecting is in what would be our ordinary template of clinic, probably about 30 to 40% of that clinic are still receiving a face-to-face interaction.
Thank you. That's really helpful. Can I just ask Matthew Groom, in his response to the chair's letter, that discussions were going to be held with the West Yorkshire Combined Authorities, because the public transport links directly to the hospital sites have been pretty ropey when you're considering how patients who don't have access to their own transport or aren't coming by patient transport services can actually access the hospital sites where these services are being delivered, and whether those discussions have taken place and whether they've borne any fruit.
No, we haven't. As I said at the beginning, we haven't picked that up because of the COVID. Obviously, NHS England has been in response to the COVID challenge, and so our teams have been redeployed as part of that. But as things are, as we're now preparing for winter and hopefully things are calming, then we'll be picking those up. And what we will be doing is sharing the consultation feedback with them and having those discussions so they are aware of the challenges that are there. I think just to go back to the point on the online consultations, I think we have to remember this is a big change in how people will be accessing healthcare, and what as we described, this crisis has given almost a step change in how that is, but it's going to take quite a few years for it to become normal, for people to be comfortable with having some of their consultation done face to face and some of it done online, some of it done by telephone, some done virtual, and so I think it's a longer game that we have, but it is a big positive generally for patients not having to travel if they don't need to travel, particularly around the follow-ups is where a lot of the focus is at the moment, around looking at the follow-ups where people are going in for, they have been assessed, they've had some diagnostic, it's a follow-up appointment, that is more likely that can be done remotely when there's less needed to be actual physical contact. But as we said, if there is needed, then it's really important that people have access and can get in and see a clinician if they need to do that. But it's not good use of people's time and also capacity in hospital if it can be done remotely, if it's a conversation that needs to happen as opposed to a physical examination.
No, but it will be something that varies a lot from specialty to specialty.
Absolutely.
And it's much more applicable where a patient is already known to the service and to the clinician who's on the other end of the line and has established a relationship and carried out a lot of exclusions so that you know what to focus on, and that you've already developed a conversation rather than for somebody that you've never actually met before. So you know, it's quite. It needs to be a lot more nuanced than sometimes comes over from the pronouncements.
No, I agree, and I think it has to be planned in. It's got to be around their individual patient and their individual care and what's appropriate for them. Absolutely, and I think where they've looked at starting this in terms of the early pilots pre-COVID were particularly around people with long-term conditions that were having regular they were well known to their consultants or their team and their specialist nurses. They were having regular contact and regular follow-ups, and what they needed that interaction, but they didn't need to travel to do that. They could do that virtually, and so I think you're right that it has to be done individually for each person, and that care plan has to be agreed with them that it's appropriate for them, because you're right, for some people won't find that comfortable and won't be happy with that arrangement as well. So I absolutely support that.
Thank you for that clarification.
Thank you. Can I ask a question about the network that you talked about previously? Because we did raise points about the acute services in CHFT not having vascular on site for other interventions that might be needed in acute procedures. So where is the build-up of the network that was talked about, like is operated in between Mid-Yorkshire and Leeds?
So I'll start with interventional radiology. So in terms of interventional radiology, there will still be the elective work happening within interventional radiology. There will still be reporting happening within CHFT. So there will still be a daily presence within CHFT of interventional radiology. And like I said, with specific regard to the non-vascular intervention, obviously acute vascular interventional radiology will be delivered at Bradford, but there is an agreement that in hours, acute non-vascular interventional radiology will be maintained at CHFT by these individuals who are working there already. In terms of vascular surgery, what you're describing is perhaps responding to an emergency in theatres in hours, or responding to or arranging inpatient reviews of patients under other specialties. There will be vascular surgeons and vascular nurse specialists delivering their clinics, administrative sessions, audit sessions, and day surgery work would continue within CHFT. So there will be a continued vascular presence in hours across the organisation to enable those inpatient reviews if someone needed an opinion on a ward, or if something was to occur within theatres, which again, as what I would say is fortunately, in 10 years being a consultant here, is fortunately very rare.
Okay. I seem to remember that we talked about other acute services needing vascular intervention out of hours as well. So would the patient have to travel to Bradford for whatever procedure they were having out of hours, or would it just be for specific vascular interventions? I'm obviously not making myself as clear as I should be, really, I think. But I think there was a need for vascular. I seem to remember a need for vascular intervention in other specialty acute procedures. Yeah.
Yeah. So out of hours. So vascular intervention, and I think I would suggest that the commonest, if you can call it common, and I'll come back to the numbers we looked at, were the gastrointestinal bleeds that are under the general surgeons or gastroenterologists. And as I covered, I think looking at all cases that truly needed out of hours non-vascular or vascular to another specialty, that was 8 cases for a year. Because the expertise would be in Bradford, the plan that is being worked up is that the patient would travel because all the staff and equipment would be present. However, as I know happened after one of our meetings on, I think it was the 17th of January, when you said what would happen, and I ended up driving to Iredale that night. In that situation, we would, in a situation where a patient is unstable too unstable to travel, you have 2 options. You have the option of, for example, if it's a gastrointestinal bleed, you have the option of the interventional radiology team travelling. The other option is, if a patient is that unstable, is proceeding directly to surgical intervention and actually treating the condition surgically, and that will be the team's call at the time as to what they feel is best.
Thank you. I think there was a concern that was raised that it would have a knock-on effect for out of hours for other specialties, that we didn't want to lose any other services as a result of this move from CHFT. I think that was where our concern was. So we wanted to be assured that the network, etc., that you said would be in place is going to be in place for your proposed November date.
There is a working group on this, and they're very cognizant of the date that we're working towards. And we're having weekly or 2 weekly, depending on which site, operational meetings, operational delivery meetings, where this is a topic that's on the on the agenda itself as an item.
Thank you. Does any of the committee have any points they wish to raise? They've not already asked questions? No. Councillor Hutchinson, do you have any further questions on this?
No, I think they've all been covered, and you know, it does appear that the great majority of the concerns that would have been raised are either have been addressed or are being addressed in an appropriate way. So thank you very much.
Thank you. Could we just talk timelines then, please? So you've said that the planned date is mid-November, and that's subject to the safety checklist being in place from all 3 trusts, and winter pressure and COVID pressures as well. So if your planned date for moving is mid-November, at what point is the decision taken that you would be okay to go ahead mid-November? I'm just trying to get a feel for if we wanted some further information, updates as to some of the items we've talked about, when those will be in place, really. Thank you.
So I would suggest that in terms of clinic templates, rotas, etc., we generally work on a 6-week timescale. So I would suggest that the initial first check, if you know, and it'll be a dynamic process. I don't think we can say there'll be one check, and if that's okay, we'll just go for it. There will be a series of checks, but I would suggest that the first check will probably be 6 weeks ahead of that, so mid-October. And then obviously that will be the first check, and then there will be subsequent reviews of that as, you know, potentially a clinical situation may change or whatever may occur due to COVID or winter pressures. But I would suggest that the first review, formal review of that checklist will probably be mid-October.
Okay, thank you. So I've made some notes from what we've been discussing. So we talked about the therapists being in place for the community services to help with the rehabilitation, and you're at business case at the moment, aren't you, with that? And we also talked about the Yorkshire Ambulance Service pathways, having the information to the committee on that, and also an assurance from Yaz that the demand will be able to be coped with. We also talk about the network being in place, and you've also going to have the meeting between the combined authority and the trusts regarding travel. And so I think as a committee, we would want that information by mid-October, so that we are assured, as far as our points are concerned, that we have raised, that they have been addressed. What does the committee feel? Does the committee feel that is okay? Yeah. Let's come in again, Niraj. I think you're on mute.
Apologies. So just wanted to clarify that these aren't the YAS clinical pathways. These are clinical pathways that we as the West Yorkshire Vascular Services have created for guidance that they have been involved in the sort of emergency pathways, how to communicate. So we've had a team including clinicians, CCGs, nurse specialists, YAS, therapists. We've had quite a diverse team create these pathways, but these are our clinical pathways that YAS have been involved with, not sort of YAS transfer pathways. So I just wanted to be clear about that.
Okay, that's fine, thank you. But I think we'd want to see those pathways. Yes, yeah. Thank you very much. Right, so I think as far as the ongoing work is concerned, we look forward to seeing some more assurance around those by mid-October. We obviously realise that is winter pressures and coronavirus dependent, is all of this, and the plan date is a movable. I take it from what you've said, the plan date is movable if there are circumstances in place that safety, etc., has not been is not in place. Yes, yeah. Okay, thank you. All right. So thank you very much for attending this morning, and we'll move on to item 7, the next steps from the committee. So how do the committee wish to proceed with the information that we're going to get in October? Do we wish now for this JOSC to conclude its work now, and for the West Yorkshire main panel to take the update in October? How do we feel?
I mean, from a pragmatic point of view, I think the West Yorkshire JOSC main panel has quite a body of work to consider, and relatively, maybe not that many scheduled meetings to consider it within. I just wondered whether continuing this for one more session to actually, given that we're all well briefed in the issues, whether continuing this for one more session might be appropriate until we've got to that readiness for go live. And then after that, it will be a matter of monitoring whether the arrangements are actually working the way that they've been intended. And that is a much longer term thing, which I'm sure could be done through the main JOSC meeting. But that's just my starter for 10.
Councillor Godwin, you wanted to come in?
Yes, it would almost be more important to see the information first before we decided whether we needed a meeting, to be honest. And I wonder whether, because if we're going to meet in this way, whether you want to make a decision when you've got the final information and reassurance from them.
Councillor Hayden, how do you feel? No, Councillor Rhodes?
Thanks, Chair. I think that the steps that Colin has put forward is a sensible one in terms of the issues that we've asked further information today. And I would appreciate, as I'm sure all members...
I'm sorry, I'm getting...
Can you hear me? Oh, there's Councillor Hayden. Can you hear me?
Yeah, we can hear you, Councillor Rose. Yeah.
Okay. And I think it might be sensible to have that next meeting diaried to suit the October date as soon as we hear that that's been set. I mean, that's a movable situation as well. So it might be advantageous to set a date by which our meeting could take place, and actually at that date ask our contributors of today to give the information that we've required and requested. that then could actually formulate the base of going forward to the full JOS committee with the detail that we've asked, which will give them, as a full committee, the total picture. So I think that's a very sensible suggestion from Colin.
Okay, Councillor Hayden.
Yeah, hopefully you can hear me. I agree that yeah, it's a very sensible suggestion, and that if it can be, as Councillor Rowe says, it can be moved around, especially given the challenges we might have in the autumn regarding COVID and what have you. So and using this kind of method, we can move it around quite easily, can't we? So yeah, I would concur with that.
Okay, Councillor Baines.
Yeah, I can see the point of having another meeting, but do we have to bring the professionals in from the hospital? You know, because I mean, you know, they should be doing the day job, not talking to us, unless we need them to do so. So if we got the report, could it not be done without calling in the, you know, the professional staff from the trusts?
Okay, right, okay. Councillor Latty, did you want to come in?
Well, yes, basically in agreement, but I think that the point that has just been made about the professional staff is well worth taking on board.
And Councillor Hargreaves?
Hi, sorry. I did agree with Councillor Godwin, but it looks like that's not the way to go. But certainly agree with Councillor Baines.
Okay, all right. So I think if we put in the diaries for another meeting, because it can be easily cancelled if it's not needed, yeah. And if we ask for the update from the trust, and then we have a look at it to see if we need people from the trust to be at a meeting, or whether we have enough assurance from the report that we need to discuss, yes. And then after that, once we've got that assurance and it looks as if there is a planned date for going live, then we will decide whether we take the rest of the discussions going forward back into the West Yorkshire JOSC. Have I summarised that correctly with everybody's points of view? Yes. Okay, everybody. Thank you, everybody, for attending this morning and coping with the technical gremlins. Thank you, everybody, and stay safe. Thank you.
Yeah, have a lovely day, everyone. Bye-bye.